Let's begin from introduction. So football, as everyone knows, it's the most popular and valuable sport in the world. And it's a contact sport, a team sport. And for me, it's a treasure for sport medicine because FIFA, the International Federation, they have a very, very good online educational platform, the FIFA Medical Network. And if you're interested in it, I highly recommend all of you to register on it, and you can take free courses on it. And after you finish all of the courses, you can get a diploma from it. And they provide the latest evidence around sport injury, not only football, but also it's kind of related to other kinds of sports. So for football, the total distance in one game is between 10 to 13 kilometers. And most of the time, you're actually doing low to moderate intensity, around 80 to 90%, and only 900 meters to around like 300 meters is in the high speed of sprinting or sprinting. So the high intensity exercise only takes account for around 10 to 20%, but it's a key of the match. So often you will see players sprinting on the court with the ball, and then it's a timing of goal. So although it's not account a lot of time for it, but it's actually very important. What I have just mentioned is football is quite popular and valuable, and so we'll keep going on. And this is the medical platform provided by FIFA. And so this is what we just talked about, a little bit about football. So you can see if you are playing football, as a football player, you need very, very good cardiovascular fitness to sustain the total game period, but also you need very high explosiveness and the ability to change the direction. And sometimes contact cannot be prevented. So that's why when we are talking about sport medicine, we will often classify it as a contact sport or non-contact sport. And sometimes the venue matters. Whether you are playing on a nature grass or artificial grass, it's a little bit different. And for sport injury, when talking about sport injury, the column here is the sheet from IOC. So every year, IOC, they will provide some injury surveillance data and using these sheets and codes. So first of all, you need to know the location, where the location is, and what kind of injury mechanism it is, whether it is acute or chronic, it's contact or non-contact. And most important of all, we want to know the incidence and severity. And a little bit more about the incidence and severity. Actually, the official record for incident is how many injuries per 1,000 athletic exposure. This is recommended by the IOC. And when we are going to record the severity, often we are using the time loss of competition or training. But as you can imagine, for some kinds of injury, for example, like overuse injury, it doesn't necessarily cause people can't play, but it will affect the performance. So sometimes we'll use auto questionnaire to replace time loss of training or competition. And when you combine the incidence and severity, you times them together, it will be the burden of injury. So from the perspective of injury prevention, actually what we should look a little bit more seriously on it is the highest burden injury. So take football as an example. The highest burden will be ACL tear and hamstring injury. So ACL tears is a very, very severe injury. It might cause like almost a year of out of competition. And hamstring injury, although it's not severe as ACL, but it happens quite often. So these two injuries are actually the highest burden of football, but it's not the topic of today's. And then let's go to the common injury. So here are some latest evidence about injury surveillance. So I picked these data from those studies. And as you can see here, they divided into women and men. So you can see gender actually makes some difference. So from injury per match, it's different from women's and men's. And also the severity is a little bit different. You can see here, there are more severe injury in men comparing to women. And the time loss per match is also different. And here you can see the injury location is a little bit different as well. For women's, they have higher percentage of head and neck injury, and for men's it's around like the thigh, but for lower leg and ankle it's almost the same. And then the injury type will mostly be sprain and contusion, and for men it's a little bit more about the strain. And if you look at the injury severity, you can see most of the injury are minor injury, and when you compare whether it's a match injury or a training injury, you can see the match injury is higher than training injury, and most of the injury are contact type, and the onset is acute injury. But here, it really depends on the definition, whether it is how do you define acute injury and chronic or gradual injury, and whether it is an pure acute injury or acute or chronic injury. So this is what we really need to know when we are looking at the available evidence. And here is the same. You can see here the burden. So the burden comes here. So you can see during the match injuries, the burden is actually high, which means the time when you're timing incidence and severity. During the match, it's even more severe than training. And also it's acute injury more in the match injuries. And this is a systematic review and meta-analysis from 2020. So you can see the injury part is mostly located around the lower limb. So for thigh is accounts the most, and then coming to the knee and the ankle. And for the injury incidence by type of injury, mostly they are musculoskeletal injury, focusing on the muscle and tendon. And overall, the incidence around the injury is 8.1 injuries per thousands of athletic exposure, and this is the data from the latest Tokyo Olympics. But what I want to emphasize is here, in sport medicine, it's not only sport injury. You can see every year the IOC level reports both sport injuries and illness. So sometimes illness matters a lot and even more. For example, like in swimming, the burden of illness and injuries is almost the same. And when you compare it to other kind of sports, you can see here football is around like the mid, but actually the severity is a little bit higher. So here the gray one and the black one is injury for causing time loss more than 1 day. So you can see it accounts for higher percentage comparing to other kinds of sports. And for detailed of these data, you can see the majority of the injury happens around your head and your ankle, and also most of them are muscle contusion and concussion and ligament sprain. And what is my personal experience? So last year in Bahrain, I went to Bahrain for the AFC qualifier. So I do some injury surveillance job, and this is official data from AFC, and it's actually quite similar. But for our data, mostly they are knee, followed by the posterior thigh, hip, and groin, and some of them do have some back and neck problem. So in a short summary, the overall incidence is around 8.1 injuries per thousand athletic exposure, and match injury is higher than training injury. And most of the injury are lower extremity injuries, and also they are mostly muscle and tendon injuries. For the injury mechanism, it's usually associated with contact or trauma, and minor injuries were the most common one. But if you got some more serious injury, it will cause a lot of time out of competition, and gender is different. And what are those common injuries? So for ligament tear, it's mostly ACL or MCL, and for muscle strain is hamstring or adductor longus, and ankle sprain, of course, is quite common. And you do have some muscle contusion, maybe on the quadricep or anywhere else you do have a direct impact. And also don't forget concussion, which is another topic for today. So let's dive in a little bit more about how do you manage the sport injury. First of all, I would like to talk about two concepts. The first one is a regional interdependence. It's actually talking about the body parts are interconnected despite the anatomical location, which means maybe now the pain occurs around your shoulder, but the actually source of the etiology or the cause is come from your hip or your ankle. And we will elaborate it a little bit further later. And the second one will be the joint by joint approach. So basically it's talking about every joint you can roughly divide it into a mobile joint or a stable joint. And how do you define the mobility of the joint? It's defined by the degree of freedom. So for example, our knee joint, you do have a lot of range of motion in flexion and extension, but actually you do not have that much of range of motion around your axial plane and your transverse plane. In contrast, our shoulder joint and our hip joint they have very, very large mobility, so they can do flexion, extension, external rotation, internal rotation, abduction, and adduction. And what the joint-by-joint approach has illustrated is usually one stable joint will be connected to one mobile joint. And the reason why it is designed for this relationship is because if you want to perform a movement effectively, you'll need a stable platform. And then a mobile one will be stick on it, and then you can perform a movement effectively. And from the early stage of sport injury, we need to really address on pain and inflammation. And we can use the concept of peace and love. So originally, when managing acute sport injury, we know it starts from rise, resting, icing, and compression and elevation. And gradually we add P into it, which refers to protection. And now we said you don't need to total rest, so we replace it by optimal loading, so it becomes POLICE. And in 2019, in a BJSM blog, some experts proposed we are using peace and love. So P also refers to protection, E as usual, elevation, and A is avoid anti-inflammatory. Because recently, some of the literature support that if we overuse the anti-inflammatory, it will actually hinder the recovery process. So it's not that proposed to use anti-inflammatory in sport injury. And C for compression, E for education, L for load, which is almost similar as optimal loading, O for optimism, V for vascularization, and E for exercise. And they really put a lot of emphasis on some psychological perspective, for example, education and optimism. And what is the highlight of this proposition is they remove ice. But actually, if you look at the evidence, whether you are going to ice the injury part or not, it's actually most of the study based on animal study. So in my point of view, you can use ice as long as it's in the acute stage. And ice is really helpful in addressing pain, but there is no reason for you to use ice after acute stage because there are some consideration of affecting the recovery process. And the second one, you need to address the range of motion. So start from passive range of motion and gradually progress to active range of motion. And you may use closed chain exercise, then use open chain exercise. For cardiovascular fitness, you don't necessarily need to totally rest. So if you got your knee injury, you can still use your hand to do some aerobic exercise or even high intensity exercise using the bethany rope. And at this stage, you really need to focus on your motor control, which is your proprioception, your movement quality, and focus on the activation of your muscle sequencing, and also start from isometric exercise and focus on your core training. And from the mid stage, still you need to address the pain, and whether you want to adopt a pain-free strategy or a pain-stressful strategy, it actually doesn't make a big difference in the hamstring study. So just pick one you like or the athlete like, and you need to view pain as an indicator instead of a contraindication for training, because pain is an alarming system. So whenever pain happens, it doesn't necessarily mean there are tissue damage. But the only exception is when you are doing some explosive movement or you are doing some plyometric exercise. So that's the reason why we will put these exercises in the later stage. And we are going to address the strengths at this stage. So start from isometric and then progress to eccentric exercise and concentric exercise. Eccentric exercise is a very important factor in dealing with sports injury, because if you want to have a good concentric force, which is your plyometric or power output, you need to have a very good eccentric ability to attenuate the force and then generate further force you want. Like, for example, like you need to learn how to land, then you can jump. And for the training, we are going to start from endurance and then gradually progress to hypertrophy and then finally reach the strength level. And at this stage, we can start some sport-specific training, for example, like landing skills, or you can do some acceleration or deceleration drills. But at this stage, it's a little bit early to do some change of direction. So from the movement plan, we might start from like flexion and extension, and then we're going to do abduction, adduction, and rotation. So start from the basic plane, and then we're still going to maintain the cardiovascular fitness. And in late stage, we are going to reach, and what our goal is, the maximal strength and power. So at this time, often we are going to compare your strengths at your affected side to your unaffected side. But be careful, sometimes or most of the time, your non-affected side is usually weaker than before your injury happens. So if you got a baseline data, it's better for you to compare the current status to your baseline data. And we are going to do some power training, and the sport-specific training will include some change of direction drills, which is agility, and also plyometric training. And finally, return to play is a process of shared decision-making. So talk a little bit more about return to play. So it's actually a spectrum. So from return to participation to return to sport, then finally to return to performance. And it's actually not like a linear process. So it's like climbing a mountain. So there's high, there's down, there's high, there's down. And you need to take all of the three components into consideration, which is your clinical expertise and also the current evidence in the literature. And most important of all is your patients. So what is your patient's feelings? Are they well prepared? These are the important factors when you are considering to return to play. Okay, so now we are going to use two sport injury as an example. So first is the ankle sprain. So the clinical presentation of ankle sprain is, I think everyone is quite familiar with it. So pain, swelling, heat, and sometimes you got difficulty weight bearing. And for the mechanism of injury, it usually happens in inversion and plantar flexion during your landing. So this is the injury mechanism of lateral ankle sprain, which is more common than medial ankle sprain. But be careful, when you got a stretch force at your lateral side, actually there is a compression force on your medial side. So when you torn your lateral ankle ligament, including your ATFL, which is your anterior talofibular ligament, or your calcaneofibular ligaments, sometimes you injure your deltoid ligament because of the different injury mechanism. And for the other lateral ankle ligament, the AITFL, it's actually included in the high ankle sprain, which we will talk about later. And the injury mechanism is different. It's from force for dorsiflexion and external rotation. So how do we diagnose ankle sprain? Except the clinical presentation, we can still do some physical examination to test the ligament integrity, and ultrasound is quite useful. So here you can see on the right corner side, this is a intact ATFL. You got like a very nice fibular pattern. And this one is a torn ATFL. It's a total complete rupture, so it's a grade 3 ligament injury. And also for ultrasound, you can do some dynamic tests. So this is a calcaneofibular ligament, and when you do inversion, you can see the peroneus longus and brevis being lifting up. It's indicating the ligament is quite dense, so it's a healthy ligament. And for treatment, firstly, of course, we are going to start from relatively rest and protection with your brace as needed, and then we will progress to some physical therapies, including the modality and manual therapy, and sometimes your movement, which is the exercise therapies. Of course, you can combine with some injection, including prolotherapy using PRP or using dextrose. And finally, if all of the conservative treatment fails or there is obvious instability, you still need surgery to fix the problem.